Hi, everybody, and welcome to our module on sodium and water balance. Sodium and water have to be kept in balance, and by this I mean that the amount of water you ingest every day has to equal the amount that you put out. This is called water balance. Similarly, the amount of sodium you take in every day has to equal the amount you put out in your urine. This is called sodium balance. And the major regulators of water and sodium balance are antidiuretic hormone, the sympathetic nervous system, and the renin-angiotensin-aldosterone system. Now, I talk about these hormones and systems in lots of other videos, but what we're going to do in this video is talk about how they all work in concert to maintain sodium and water balance. And the reason this is important is because sodium and water balance questions are the basis for many renal physiology questions that will appear on school exams and the USMLE Step 1 exam. Before we can talk about sodium and water balance, we have to review a couple of important concepts. And the first one is the concept of the effective circulating volume. This is a portion or part of the extracellular fluid in the body that is contained in the arterial system and maintains tissue perfusion. The reason the word effective is in the name is because this is the portion of the extracellular fluid that is effective at tissue perfusion. And as we will see, it is not necessarily correlated with total body water. There are certain states where you can have excess total body water, but your effective circulating volume is actually decreased. The effective circulating volume in the body can be modified by three factors. First of all, it can be modified by the total volume of fluid in the body. Under normal circumstances, if you increase or decrease the total volume of fluid in the body, you similarly increase or decrease the effective circulating volume. This volume can also be modified by cardiac output. If you raise your cardiac output, you will increase your effective circulating volume even though there is no change in total body fluid. This is because the fluid in the arterial system is more effective at perfusing tissues when the cardiac output is higher. You can also modify your effective circulating volume by changing the vascular resistance. If there's a significant drop in vascular resistance, this can lead to a very low blood pressure and a very low effective circulating volume, even though there has been no change in the total volume of fluid in the body. And under normal circumstances, the major determinant of your effective circulating volume is your sodium intake. If you consume excess sodium, you raise your ECV, and if you restrict your sodium consumption, you lower your ECV. And we're going to talk about this in detail later in this video. One of the ways you can estimate the effective circulating volume clinically is by looking at the blood pressure. Low effective circulating volume can lead to low blood pressure. In addition, a classic sign of low effective circulating volume for any reason is orthostatic hypotension. Patients who have low ECV when they stand up will have a significant drop in their blood pressure. This is called orthostatic hypotension, and this can lead to dizziness or fainting on standing. The most important point about ECV that you need to understand as a student is that anytime the effective circulating volume is low, it activates both the sympathetic nervous system and the renin-angiotensin-aldosterone system. And these two systems, via a number of mechanisms that I discuss in other videos, leads to retention of sodium and water by the kidneys. And the idea here is that these two systems are in place to protect us from volume loss. So anytime the ECV is low, these two systems lead to retention of sodium and water with the goal of restoring the effective circulating volume to normal levels. In some disease states, however, the ECV is chronically low, and this leads to chronic activation of the sympathetic nervous system and RAS system. This in turn leads to chronic retention of sodium and water by the kidneys. Now, you might think that chronic retention of sodium and water by the kidneys would lead to an increase in the total amount of fluid in the body. Sometimes this is the case, but not always. Depending on the disease state, you may or may not see an increase in the total body water. To understand this better, let's look at the chart as shown on the screen here. These are the three classic pathologic conditions in which the effective circulating volume is chronically low. They are volume depletion, heart failure, and cirrhosis, and let's go through them one at a time. So first, let's consider volume depletion. For example, imagine a patient with nausea, vomiting, and diarrhea who is significantly volume depleted. This patient will have a low ECV, which will lead to activation of the sympathetic nervous system and RAS systems. Those systems will lead to retention of sodium and water by the kidneys, but the kidneys won't be able to keep up with the volume losses. Thus, the total body water for that patient will remain low. In heart failure, the situation is different. Heart failure patients have a low cardiac output that causes a low effective circulating volume. This activates the SNS and RAS systems, which leads to retention of sodium and water. This, however, does not correct the effective circulating volume problem. Because of the heart failure, the ECV remains low, and thus patients with heart failure develop an increase in total body water, but the problem is that the water is in all the wrong places. It's stuck in the venous system, and thus heart failure patients are congested. So the important point here is that in heart failure, there's a mismatch between ECV and total body water. The ECV is low, but the total amount of water in the body is high. In cirrhosis, patients have a very low systemic vascular resistance from vasodilation. This leads to a fall in ECV and chronic activation of the sympathetic nervous system and RAS systems. This leads to retention of sodium in water, but that is unable to resolve the low SVR problem. Thus, cirrhosis patients, just like heart failure patients, develop an increase in total body water with the fluid in the wrong places. As you know, patients with cirrhosis have ascites and pitting edema, and this is all from an increase in total body water in the setting of a low ECV. All right, we're almost ready to discuss sodium and water balance, but first we have to review one other concept, and that is the way that antidiuretic hormone works. Antidiuretic hormone is often called ADH or vasopressin, and it leads to retention of free water by the kidneys. I talk about the mechanism of this hormone in detail in the video on nephron physiology. Now, under normal physiologic circumstances, the major trigger for release of ADH is the plasma osmolality. This is sensed by the hypothalamus, and ADH is released by the posterior pituitary gland. An ADH release leads to free water resorption by the kidneys, and through ADH, the kidneys modify water retention to maintain a normal serum osmolality. Now, although the plasma osmolality is the major trigger under normal physiologic circumstances for ADH release, there is a second trigger that you need to understand, and that is low effective circulating volume. This is called the non-osmotic release of ADH. It's a second trigger in addition to serum osmolality, and this trigger is only activated when the ECV gets very low. So this is not going to be activated by mild swings over a normal day of your ECV as you consume water, fluids, or sodium. This is only going to be activated in settings when the ECV is very low, like those three settings we talked about before: volume depletion, heart failure, and cirrhosis. In all three of those settings, the ECV can get so low that ADH is released no matter what the serum osmolality is. In other words, the low ECV takes over as the trigger and leads to ADH release no matter what the serum osmolality may be. Now we're ready to begin our discussion of sodium and water balance, and let's start by talking about water balance. So the plasma sodium concentration is maintained by the body at about 140 milliequivalents per liter. To maintain this concentration, anytime you take in water, that water must be excreted so that the sodium level stays normal. And our water balance is maintained by antidiuretic hormone. ADH release leads to retention of excess free water, so the body modifies the amount of ADH in order to modify the amount of water that is being excreted. And your water balance is reflected by your plasma sodium concentration. When you have a normal sodium concentration, this means that the amount of water coming into your body is equal to the amount going out. In other words, you are in balance. Hyponatremia represents a state of being out of water balance. In hyponatremia, there is more water coming in than is going out. And conversely, in hypernatremia, there is less water coming in than is going out. Hypo and hypernatremia are states in which the body is out of water balance. The way the body maintains water balance under normal conditions is shown on the screen here. When you consume excess water, this briefly lowers the plasma osmolality by diluting the solutes. This will trigger a decline in ADH release, and therefore there will be less water resorbed by the kidneys. This will lead to more water being excreted, and thus the excess water you took in is matched by water excretion, and the plasma sodium level stays normal. If you restrict the amount of water you take in, this will very briefly raise the plasma osmolality. This will lead to a rise in ADH release. The body will retain or resorb more water from the kidneys, and this will lead to less water excretion. And thus, when you are restricting your water intake, the body matches that by excreting less water. To drill down on this further, let's take a look at the graph I've drawn on the screen here with time along the x-axis and total body water or effective circulating volume along the y-axis. And let's imagine that we begin at a point in time where the body is in water balance so that water coming in equals water going out. The ADH level is at baseline and the plasma osmolality is normal. Now let's imagine that we begin consuming a large quantity of water. This will lead to a situation where we're taking in more water than we're putting out. This will dilute solutes in the plasma and lower the plasma osmolality. The body will sense that decrease in plasma osmolality and begin decreasing the amount of ADH released by the pituitary gland. This will lead to more water being excreted by the kidneys so that the amount of water going out is now greater than the amount coming in, and this will raise the plasma osmolality back up to a normal level. This will then restore water balance so that we come back to a point where ins are equal to out, our ADH level goes back down to baseline, and our plasma osmolality becomes normal. And if you don't believe what I've shown on the screen here, you can prove this to yourself with a simple experiment. Consume a large amount of water, and what you will find is that your weight will briefly go up. That's because your total body water and your effective circulating volume have gone up. But within an hour or two, you will begin urinating more water and you will return to the same weight that you started at. And that's because of this whole process I've shown on the screen here. When you consume excess water, ADH release is modified so that you excrete the water and you end up back in a state of water balance where your plasma sodium and plasma osmolality are normal and your weight or total body water or effective circulating volume are back to the baseline level. Now let's talk about sodium balance, which is a little more complicated than water balance. So just like we said before, the plasma sodium concentration is maintained by the body at about 140 milliequivalents per liter. So when you consume excess sodium, sodium is an osmol, so this will lead to a rise in the serum osmolality. This will be detected by the body, and that higher osmolality will lead to water retention, which will keep the sodium concentration normal. In other words, the body is retaining water to match the sodium you have consumed. The water retention will lead to a rise in the ECV, and this leads me to a very important point, that sodium intake expands your total body water and your ECV, and this is very different from water intake. We saw earlier that when you consume more water, your ECV goes up and then comes back down when balance is restored. Sodium is different. When you consume sodium, your ECV goes up and it stays up. We'll talk more about that in the next few slides. This slide shows how the body responds to restricted and excess sodium intake. So when you restrict the amount of sodium you consume, you briefly lower the plasma osmolality. This is sensed by the body, and the amount of ADH released by the pituitary is decreased. This leads to less water resorption by the kidneys and more water excretion. By excreting more water, the plasma sodium level will become normal, but the price of maintaining that normal plasma sodium level is that the ECV falls. Conversely, if you consume excess sodium, there will be a rise in the serum osmolality. This will lead to more ADH release and more water resorption. This will lead to less water excretion, and thus the plasma sodium level will stay normal, but the price you pay for that is an increase in your ECV. And if you've ever gone out and eaten a very salty meal like Chinese food with lots of sodium, what you will see the next morning is that your weight is up. That's because your body is decreasing the amount of water that it's excreting, it's increasing the amount of water resorption. This keeps your plasma sodium normal, but what you will see when you step on the scale the morning after a salty meal is that your weight has gone up. To drill down on this further, let's return again to our chart of time versus total body water, or ECV. And once again, let's start at a state of sodium balance where the amount of sodium going into the body is equal to the amount of sodium going out, and the ADH level is at baseline. Now let's imagine that we begin consuming a lot of sodium. For example, imagine that you go out and eat a very salty meal. This will raise the plasma osmolality because you're consuming more sodium than you're putting out. That will be sensed by the body, and the amount of ADH released by the pituitary will go up. The body will then begin retaining water, and the amount of total body water, the y-axis on this chart, will begin to rise. This will keep the plasma sodium concentration normal, and then the ADH will come back down to the baseline level. So what we've done now is, by releasing more ADH and retaining water, we've kept the plasma sodium concentration normal. But we still haven't fixed the sodium balance problem. We're still taking in more sodium than we're putting out. So now what we need to do is talk about how the body fixes this problem, and that involves the renin-angiotensin system and the sympathetic nervous system. So your effective circulating volume is controlled by the sympathetic nervous system and the RAS system. These systems are activated when the ECV gets low, and they are inhibited when the ECV gets high. As you know, your ECV gets low in states of volume loss or hemorrhage, and that's what these systems are designed to protect us against. So anytime the ECV becomes low, these two systems are activated. And sodium can alter these systems because sodium can alter the ECV, and therefore it can modify the sympathetic nervous system and the RAS system. As we saw 2 slides ago, when you take in sodium, you expand the ECV. This expanded ECV decreases the activity of the sympathetic nervous system and the RAS system. This in turn will lead to increased sodium excretion and restore balance by making sure that the amount of sodium going out of the kidneys matches the amount coming in. And here's a flow chart showing you how this works. So when you restrict your sodium intake, you shrink your ECV. This increases the activity of the SNS and RAS systems. This leads to sodium retention and less sodium excretion, and therefore the restricted sodium is matched by decreased excretion, so sodium balance is maintained and in equals out. Conversely, when you consume excess sodium, like going out to a restaurant, your ECV expands, your sympathetic nervous system and RAS systems are dialed down, there's less sodium retention and more sodium excretion, and thus once again, sodium balance is maintained with in equal to out. Let's return to this graph one final time, and once again, let's begin in a state of sodium balance where sodium in equals sodium out. At this point, our ADH level is at baseline, and the activity of our sympathetic nervous system and RAS systems are also at baseline. We then begin consuming excess sodium. This leads to a situation where sodium in is more than sodium out. This raises the plasma osmolality, and because of the higher plasma osmolality, our ADH level goes up. Because ADH goes up, we will begin to retain more free water. That will normalize the plasma sodium level and return the ADH level to baseline. However, the excess water that we have retained has increased our effective circulating volume, so we've moved up along the y-axis. Because of the higher effective circulating volume, the sympathetic nervous system and RAS systems will be dialed down. This will lead to more excretion by the kidneys of sodium, and this will restore sodium balance. So once again, sodium in will equal sodium out because we have dialed down the sympathetic nervous system and RAS systems to make up for the increased sodium consumption. So now we have returned ourselves to water and sodium balance, but in order to do so, we had to increase our ECV and we had to get to a state where our sympathetic nervous system activity is decreased and so is our RAS activity. Now I've wiped away my ink so I can make an important point. You might be inclined to think that the sympathetic nervous system and RAS systems would drive the ECV back down to the level where we started, but that's not the way these systems work. Under physiologic conditions, the SNS and RAS systems are designed to maintain sodium balance, not necessarily to maintain a constant ECV. And at this higher point on the curve shown here, we have achieved sodium balance. In is equal to out. What this means is that the body is going to continue to operate at this higher ECV as long as sodium consumption remains high. If we continue to eat high salt foods day after day after day, we will continue to operate at a high ECV. The only thing that will return us to a lower ECV is if we stop eating high salt foods. If we go back to a lower level of sodium consumption, then our ECV will fall back to the level where it started from. And if you want to prove this to yourself, try eating a bag of potato chips every day for a few days. You will see that your weight will go up and it will stay up. And the reason it's staying up is because you're consuming lots of sodium and therefore your body is operating at a higher ECV. So on this slide, I've summarized some key points. High sodium intake expands the effective circulating volume. Clinically, you can see this as weight gain, and in some patients, this can cause hypertension. A high sodium intake is one of the potential causes of hypertension, and that's because sodium expands the ECV. On the contrary, low sodium intake contracts the ECV, so if you start eating a low sodium diet, you will see your weight go down over the next few days, and eating a low sodium diet is also one of the ways to improve blood pressure in patients with hypertension. I'm going to finish this video by talking about pathologic states where sodium or water are out of balance, and these states are very easy to understand if you understand the principles of sodium and water balance I just went through. First of all, I want to make a general point. When a pathologic state leads to a lack of water balance, this is reflected by abnormalities of the plasma sodium level. So hypo or hypernatremia are problems of water balance, not sodium balance. In contrast, when there's a problem with sodium balance, this leads to alterations in the total body volume or effective circulating volume. So hypo or hypervolemia are states in which there are abnormalities involving sodium intake and output. I'll finish this video with a couple of clinical correlations of sodium and water balance, and the first one is GI losses. So patients who have nausea, vomiting, and diarrhea have GI losses of salt and water. This leads to contraction of the effective circulating volume and activation of the sympathetic nervous system and RAS systems. In addition, the volume loss leads to ADH release. This is that non-osmotic release of ADH. It's driven by volume sensors, not plasma osmolality sensors. So when you are in a state of significant GI losses, you are in a hypovolemic state, and ADH will be released no matter the plasma sodium level. In other words, the ADH level is no longer controlled by the plasma sodium level. This means that water balance control by ADH has now been lost. Free water is going to be always retained by the kidneys because the ADH level is always high. In this situation, your plasma sodium level is determined by your relative intake and losses, and thus it is very easy to develop hyper or hyponatremia in the setting of GI losses because the ADH release is no longer controlled by the plasma sodium level. What more often happens with GI losses is that patients develop hyponatremia. This is because they're drinking free water because it's easy on their stomach. In addition, they're often not eating, which means they're not consuming any sodium. This just worsens the volume loss and leads to more retention of free water that dilutes the plasma sodium. Hypernatremia can occur in some situations, however, if the patient is not taking enough free water to match the free water losses from their GI tract. Heart failure is another clinical example where sodium and water balance can be lost. Heart failure patients have a chronically decreased effective circulating volume because of low cardiac output. This leads to chronic activation of the sympathetic nervous system and RAS system. Thus, sodium is chronically retained by the kidneys of patients in heart failure. In addition, free water is retained to balance out the sodium that the kidneys are holding on to. This leads to a situation where sodium balance is disrupted. In heart failure patients, sodium excretion is always reduced by the kidneys. Thus, if a heart failure patient consumes a high sodium meal, they will easily get into a situation where intake is greater than excretion and they are out of balance. And as we discussed before, when you have excess sodium, this leads to hypervolemia, which is common in heart failure patients. Another problem that heart failure patients have is that the ECV does not increase normally with fluid retention. So if a person with a normal heart consumes a high sodium meal, their cardiac output and their ECV will go up. However, patients with failing hearts are unable to increase their cardiac output. Therefore, they always have a low ECV even after they consume excess sodium. The result is that they get congestion, which is typical of heart failure patients. They have lots of extra volume in their body, but it's in the wrong places. It's not going into the effective circulation system. Therefore, they develop congestion symptoms like pulmonary edema, elevated jugular venous pressure, and pitting edema. As we discussed before, in heart failure, the ECV is always down, but the total body water goes up for the reasons discussed on this slide and the last two slides. In addition to sodium balance problems, heart failure patients have a water balance problem. The low ECV leads to chronic ADH release. ADH is always high in heart failure patients, and once again, this is driven by the volume sensors its non-osmotic release of ADH, and therefore the ADH level is no longer controlled by the plasma sodium level. This means that water balance control by ADH is lost and free water is always retained by the kidneys, so the plasma sodium level is determined by the relative intake and losses. And for this reason, hyponatremia is very common in heart failure patients because they often drink more free water than they need, and this leads to hyponatremia. I'll finish this video with one slide on SIADH, which is the syndrome of inappropriate ADH secretion. SIADH causes hyponatremia, and I talk about it in detail in the video on sodium disorders. But what I want to focus on here is the physiology, which is very easy to understand if you understand everything we've been talking about in this video on sodium and water balance. As the name implies, in SIADH there is excessive ADH release from the pituitary gland. This leads to water retention, which causes hyponatremia. Now you might think that water retention would cause the patient to develop hypervolemia, but that does not occur. Patients with SIADH have a normal volume status. And the reason for this is because of all the things we've been talking about in this video. When the initial water retention occurs, that expands the effective circulating volume, which decreases the activity of the sympathetic nervous system and the RAS. When that happens, there is increased sodium excretion, and that brings the ECV back down to the normal range, and therefore volume status is normal. So the key clinical findings in patients with SIADH are hyponatremia because of water retention, a normal volume status because the sympathetic nervous system and the RAS have been dialed down, and a concentrated urine because ADH levels are high and water is being resorbed. All of this makes perfect sense based on the principles of sodium and water balance. And that concludes our module on sodium and water balance.